Hello, everyone. I'm Mary Dixon-Woods, and I have the great privilege of being the director of this institute. This institute is funded by the Health Foundation to produce an evidence base for improving quality and safety in healthcare. And at age 75, this is an agenda that is increasingly relevant to the NHS. Over the last year, this institute has been delivering on the strategy that was agreed by the Health Foundation board last year. And we're focusing our efforts in three areas that are particularly helpful to the NHS. And these three areas comprise an improvement learning system. The first element of this is the capacity to characterize and understand problems. The second is the ability to develop possible solutions. And the third is the ability and capacity to evaluate them. I'm just going to talk you through what that looks like in practice. So it's very important to the NHS that the ability to characterize and understand problems is as strong as it possibly can be, because it's needed to tackle challenges that the NHS has always faced, including variations in rates of interventions and in outcomes and processes. And despite many years of research, those variations have turned out to be remarkably persistent. So challenging those variations requires deep understanding of the problems. And that means that understanding the problem is the first key step in securing improvement. One of the areas in which we've been doing most research in terms of understanding the problem is on the area of voice, including patient and staff voice. One of the things we've discovered is that in order to understand whether something is a problem, you first need to understand whether it's a voiceable concern. And by a voiceable concern, we mean something that either a colleague or a patient can give voice to. And there are four influences on voiceability. The first is that something is wrong, certainty about something being wrong and an occasion for voice. The second is whether the issue under consideration is a system issue or a conduct issue. The third issue is forgivability, so the extent to which it can be excused given the circumstances. And the fourth is normalization. And all of those things combine together to make some issues unvoiceable, not because they are not problems, but because they challenge the ability of people to give voice. So that's a very important step in understanding influences and voice. But we know that voice futility is an ongoing problem. So essentially that people do not give voice even when there are concerns, even when an issue is being pointed out and people are being told about it, there may not be an organizational response that is appropriate. And we've linked this to a spectrum of behaviors which can be characterized on a spectrum from problem sensing, which is where organizations are out deliberately and intentionally using multiple techniques trying to find problems, through to comfort seeking, where essentially it becomes possible somehow to find comfort in the existing information and not to be challenged about it. We also know that an influence on people's ability to give voice and to be heard and for action to follow is the difference between the formal organization, the stuff that's in policies and procedures and so on, and the informal organization, which is what people learn from being in the organization and the norms that determine behavior and behavior in relation to voice as well. So both the formal and the informal organization may be very helpful actually in promoting voice, but they can also have their dark sides. And it's very important that we understand what some of those dark sides can be. We know, for example, that it's particularly difficult when soft intelligence exists in organizations about particular problems. How that can be turned into something that is actionable is a real challenge as concerns get processed through organizational systems. And this leads us to the need to have different ways of listening, and also to understand how they function in practice. One of the studies that we've done has looked at, for example, the Freedom to Speak Up Guardian. And this turns out to be variably implemented, and lack of clarity yet about the extent to which it is enabling voice and the extent to which it's then possible to secure action in response to concerns that are raised. It remains the case that systems for responding to concerns and complaints do not always address the needs of patients, families, and healthcare staff. And the reasons for that are complex and multiple, but it is very often the systems are not sufficiently well engineered to cope particularly with more complex problems. Once the issue has become known as a problem, there's then the question of understanding exactly what it involved. And there is often a difference between problems as imagined and problems as they really are. And if we don't really understand what the problem is, there is a real challenge that the improvement attention may be misdirected. We've just completed an analysis of the influences on safety for electronic fetal monitoring, for example. And here, where the problem had been characterized for a very long time as one of individual technical proficiency, what we've been able to show is instead it's a complex socio-technical system that requires a very different approach to improving it. Similarly, if we're going to tackle challenges like erosion of compassion in acute mental health services, then we have to look at the systemic and institutional forces that act on staff's ability to demonstrate compassion. The very famous guru of improvement, Edward Deming, said that outcomes depend on structures and processes. And it's absolutely clear that getting structure right is absolutely vital. It's essential to improvement. If you don't have the right facilities, the right staffing, the right organizational characteristics, the right equipment, then healthcare improvement cannot occur. In fact, it's difficult to deliver care at all. But what we also know is that not all variability in outcomes can be explained by variability in structure. So processes are a very, very key area for attention. We need to look at the actions that are ongoing and how processes support those. And we know this because there is evidence that organizations and units that appear to be very similar structurally have very different outcomes. And this is something that means that we should be focusing, as well as our quite right emphasis on structure, also looking at processes. And when we look at processes, we find, for example, that this excellent study that characterized how GPs are spending their time, that they're constantly frustrated by weaknesses in processes. We also know when we are studying processes that we have to be very, very careful about biases that can intrude into the data because of the way discrimination may surface in, for example, electronic coding. And that's going to be increasingly important as healthcare begins to rely on AI, that we do not engineer in biases already in the system. A second important and crucial element of a learning health system then is the ability to develop possible solutions. And if we look at the NHS, it's not like there is any shortage of recommendations and ideas about how to improve it. But what we do lack is an evidence base for many recommendations, a system for prioritizing and coordinating recommendations, high quality design, testing, and evaluation. We know that many improvement recommendations are poor quality, they're not based on evidence, and they have not involved patients or staff in their design, implementation, or evaluation. And the sheer number of recommendations coming at the NHS results in the problem we call priority thickets, which means that there's so much that they're expected to do, it's very difficult to find clarity and a way through to what needs to be done. We also know that when you use techniques from other industries that help diagnose systems, it can remain difficult to prioritize risks that have been identified in systems but have not yet resulted in an incident, simply because there are so many other competing considerations for time and improvement resource. So what is very clear is that we need inclusive ways of prioritizing targets for improvement. And at this institute, we've been trying to do this using consensus building methods, for example, on the priorities for improvement in general practice. And we've been able to use both GPs and patients to go through exercises where we can identify what matters to them. Also clear is that we need more emphasis on issues that get neglected as a focus of improvement activity and improvement focus, including what we know from other industries, the importance of competent management, including HR systems. The NHS absolutely has to have capacity and capability for improvement, and that means knowing what the evidence is behind different approaches. So one of the great achievements of the last year of this institute has been the launch of our Cambridge Elements series on improving quality and safety in healthcare. We now have a new element or chapter appearing approximately every month or 6 weeks. And each of these offers an authoritative overview of an improvement approach and is completely free to use. So please do access as much as you like. What we do know is that without large-scale coordination, large-scale design waste occurs. What we see in the NHS is a proliferation of small, time-limited, poorly coordinated projects. And small local projects are absolutely essential to improvement, but we're not always targeting the design capabilities at the right level. What this can mean is a large amount of design waste, for example, that we can see in the phenomenon of systems for detecting deteriorating patients. So if we look at early warning scores, there was a proliferation of local systems throughout the 2000s. This led to a lot of effort and unwarranted variation in tools, which finally was rationalized in 2017 with a national early warning score. We're seeing the same phenomenon in pediatric early warning scores, where there was a huge amount of local variation. And again, that means a lot of local effort involved in developing local systems, which has just in the last few weeks been rationalized through a national pediatric or early warning system. And a very similar phenomena has occurred in obstetric early warning scores, where there are almost 150 different obstetric early warning scores and escalation policies, many with hugely variable thresholds for intervention and definitions of what constitutes normal. So we have got to do better in finding solutions that work, and that means that the NHS needs large-scale co-design capabilities. And that also means that we have to have much, much more inclusion in how models, tools, and systems are co-designed and evaluated, that includes staff at every level, in every role, and that very, very critically involves patients in all their rich diversity. One of the ways we've been trying to do this at this institute is through the platform we developed, now hosted at this labs, which is called Discovery. And through now a very large number of projects, we've been able to use Discovery and other techniques to mobilize the lived experience of patients, carers, and people who work in health and care. And for example, that helps us to understand the different perspectives of patients and clinicians on care for chronic diseases, and for the different perspectives of service users, carers and staff, for remote mental health care, and for we've been also able to use it to understand the different priorities of groups in developing a quality framework for remote antenatal care. We're very clear that good co-design builds on sound theories of change, and that's got to be informed by inclusive principles. So theories of change sound a bit highfalutin, but they're absolutely critical to understanding what the goals are, and then the mechanisms that need to be used to achieve those goals. Another very good source of evidence about how to design good solutions is from the literature. We can look at, for example, as colleagues here in this institute have been doing, we can look at law, but we can also look at specific interventions and what can be learned about what works and what doesn't from, for example, systematic reviews. Further source of very important ideas about solutions comes from positive deviance. Organizations or units that are doing particularly well are a very rich source of information about the kinds of things that need to be done in order to achieve that good practice everywhere. Crucially, it's really important that human factors and ergonomics principles informs design, and some of the things that we've been working on here at this institute are very mundane things, like the design of trolleys and kits for handling emergencies, and also using things like co-design methods so that you're able to experience-based co-design methods so that you're able to include the views of many different users in developing a solution. We've also been codifying some of the methodologies for doing this, and we're looking forward to doing more of that. So we're very clear local improvement capability will always be needed. And some of what we're working on now is what good looks like in small scale surgical improvement efforts. Very nice collaboration with the American College of Surgeons and the Q communities and others to develop that quality framework, which we hope to publish over the next year. But at every stage, patients and staff have to be involved. The third part and final part of the learning system, although this is a cycle, is the capacity for evaluation. And it is just essential that that capability is there in the NHS, because what we know is that many improvement programs are never evaluated. We've just completed a review of major initiatives in the area of maternity since 2010. Many of them lack a retrievable evaluation report, although there have been over 50 initiatives. We could quality assess 15 of those improvement programs, and we've identified multiple weaknesses in those, including poor transparency of reporting, weak implementation strategies, not involving women and families, not having an evidence base for their interventions that's cited, and so on. Also clear is that evaluation has to focus on the difference between solutions and imagined and how they actually play out in reality. So process evaluation is a key element of evaluation. Evaluation isn't just what works or what doesn't, it's also why and what does it cost. So we've been looking at, for example, interventions such as perioperative care and qualitative methods making a big difference there to understanding what's needed to implement. We know that new technologies are going to pose new challenges for work and experience of healthcare, but also how to co-design and evaluate them. And some examples of those challenges are going to be evaluating effectiveness, redesigning work systems, determining whose interests are being served by new technologies, governance and accountability, ethics and law, costs, relational aspects of care and work, and equity, diversity and inclusion. So the NHS needs to have capabilities in all three components of a learning health system, and healthcare improvement research is there to serve that need. The future of the NHS, we believe, lies in large-scale research, design, process improvement and evaluation, and developing local capability. You are all very important in that effort, and we are so grateful to the Health Foundation for supporting the work that we do, which we believe is essential.
Thank you, Mary. That was an incredible presentation. And as someone who's been a doctor and a patient, it's really given me food for thought. And when I think back to all those tick box audits I had to do as a junior doctor, are they really worth their time? And how can we make sure that this work is being used to actually help patients and improve healthcare? We've had a couple of questions come in. And the first I'd like to ask is from Alison. And she said, is there anything that you would take away from the current crowded healthcare landscape to make it easier to embed improvement in the NHS?
Thanks very much, Alison. That's a great question. How could we make it easier to embed improvement in the NHS? Some of that, I think, is actually going to be about producing really compelling examples of what kinds of difference you can get from doing improvement really well. I think a second is actually what Liz has just said, that widespread engagement, empowering people, making them feel they've got a voice, enabling them to have a say, coordinating those activities at scale so it doesn't feel like some lonely activity that you're having to do by yourself without ever making a difference. And I think the third thing is that it is ensuring that the effort to improve becomes part of normal practice. It's just as normal as doing anything else, that commitment is there and practiced consistently. Thanks very much, Alison.
Thank you. And before I go on to the next question, I just want to say hi to some of the people who've come into the chat. Martin, Stella, Julie and Helen, keep on networking. Our next question is from Mike Chitty, who has said, to what extent is a benign or supportive national government a critical factor in improving or even just maintaining standards of care?
Government is really critical. You have to have that structure for organizations to work in. You have to have the funding, you have to have the investment. The end of healthcare that studies that is typically health policy. What we're about here in this institute is essentially figuring out what can be done within the current structures to make improvements. My sense is that we could do better with many areas of practice. I mean, we continue to see large-scale programs rolled out without the design effort being put in upfront and without the commitment to evaluation. And that means, firstly, that the accountability isn't there. You don't know whether the program worked or didn't. It means the engagement isn't there because patients and staff haven't had a say in what it's going to look like. And it means that they're not those programs aren't always designed to the best standards that we would expect if you were using the evidence. So that's a complicated question, but I think we could do better with given the structures that we have to work in. Thank you, Martin.
Thank you. Now, I wanted to ask, I often think that the government and the NHS are quite short-sighted, and they want to do a project that's going to save them money next year, not a health prevention program such as exercise to reduce the risk of heart attacks that will save money 10, 20 years in the future. How can we help drive that change and make them realize it's important to think about the long term?
That's a really important way of thinking about this. And I think the short-termism and looking for quick fixes is a real problem, particularly for improvement. I mean, the reality is many of these programs take many, many years to see their effects. And there are no magic bullets with a lot of this. It's often a lot of effort, it's a lot of engineering, it's a lot of relationships, it's a lot of really hard work. Again, I think having an evidence base behind this is really key, because that's what produces, in the end, the conviction, the ability to persuade, the use cases, the commitment is if you can actually show doing it a better way gets you to a better place. Thanks, Liz.
Wouldn't it be great if everyone thought just like we did?
Indeed.
Now, our next question comes from Christopher Oldroyd, and he said, the current model seems to ask busy clinicians and nurses to also be the ones doing the improvement. Do you think this can be built upon, or do we need specific teams with specific time and thinking space to actually do the improvement work? Whose role is it?
Thanks very much, Christopher. I think about this question a lot, and I think first, the work of trying to do the improvement can be quite frustrating for busy professionals, as you say, when they're expected to fit it in on top of an already extremely pressurized role. And it may not feel valued, it may feel under-resourced, it may be quite frustrating in terms of the ability to make change. I also think trying to pick up the skills, you know, in really technical areas like human factors and ergonomics and design isn't feasible in the same ways it's not feasible for me to pick up doing surgery. But there's something very, very important about the professional perspective, in the same way there's something very important about the patient perspective. So I would never want to do improvement without professionals being involved. But I do think that there is a case for having really highly trained people who know how to do process improvement, who know how to do that diagnostic work, who know how to build and test solutions. I think there is a real case for professionalizing that, but making part of that professional work the skills and ability to work alongside professionals and staff, to respect them and to include them at every step of the way. I think the model of essentially delegating it all back down to busy professional staff isn't making change fast enough. And I think there's also a case for, as I was trying to point out in the talk, I think there's also a case for aggregating those many small bits of effort that people can make. So you're doing it at scale rather than everybody doing lonely work and sometimes reinventing wheels locally. Thanks very much, Christopher, and great to have you here.
I was really interested by your comments about voice, and having been a doctor and a patient, what I think is normal as a doctor, as a patient, feels very, very abnormal. And I think my husband said this with a waiting list. There are people who are very intelligent, who know what to say and how to complain to get bumped up to the top. Whereas a lot of people will just sit and wait and wait and wait. And Danielle Doyle asked, how can we address voice futility?
Voice futility is a huge challenge, and it appears in many different guises, and some of it is very hierarchically patterned, which I think is what you're saying, Liz, but some of it is also very socioeconomically patterned. There are people who are skilled at figuring out what needs to happen. There are people who kind of understand the system and they can press the right kinds of buttons, and there are people who aren't. Voice is sometimes seen as something that gets frustrated because there are sinister forces working behind the scenes to thwart people. And it's certainly clear, it's certainly the case that not all organizations are good at supporting voice, and they may become vengeful, for want of a better word, when faced with very uncomfortable reports of things going wrong. That to me seems like a fairly specific class of things, and we have a big literature on whistleblowing and all the rest of it that confirms that. I think the bigger problem is the kind of thing you're talking about, and it may be concerns and issues that are much less dramatic, shall we say. They're kind of things that aren't going well all the time. And I don't think we have good ways of making sure that people can speak, but I also just don't think we have good ways of making sure that the listening is there. And there is voice futility arises when essentially people feel there is no point in saying anything because nothing is going to happen. And it comes back to what some of the earlier questions were asking about, which is that voice is futile unless there is a way of making the improvement. So we have to have the improvement systems in place. We have to know how to make the improvements. We shouldn't have a situation where when somebody reports a problem, there is no ability to fix it. Nobody knows how to fix it, or there isn't a methodology for doing it, or it's essentially exceeding the capability of the organization to do it.
That's a great answer. And I think I wanted to raise a TripAdvisor question, because I think a lot of the voices you get are the people with a lot to complain about or a lot to say. And most people can't be bothered to say what they think, but they could be really, really arguing at home. And often it's white, intelligent, white middle-class people who complain. And how do you get the voices of the more diverse areas of society? So we're really helping everybody.
Yeah, I've been thinking, and the team here have been thinking about this a lot recently. One of the things, it was Graham Martin who led that work on openness, and it's really, really super work. And one of the things it shows is that organizational systems for processing voice basically tend to degrade it. So it strips it of context. It turns it into something that's got to be a concern or a complaint. Sometimes all people want to do is provide some feedback. They're not complaining, they don't have a concern, but they can see a better way of doing something. Sometimes they may want to express the love. They may want to say this was a great experience. And it's actually quite difficult to process that through the organizational systems we have at the moment. I also agree with you that an awful lot of what is now voice appears in non-traditional channels. They appear on social media. They appear in all kinds of guises. I mean, I sometimes use the example of a patient from the States who was in an ICU bed for for quite a long time and experienced ICU delirium. And she posted a picture of what she could see out of her window by day, and it looked completely benign. It was just a sort of balcony with a bit of decoration in it, but by night this thing looked absolutely terrifying, and it had a huge impact on her. Now, how would you even feed that in through a normal complaints process? All she wanted to do was say, this is the problem I had. You may need to think about a different way of putting a blind on the window or whatever it's going to be. So I think we need new ways of listening to voice. And I think you have made an absolutely crucial point about the ways in which people from disadvantaged backgrounds may wish to give voice, how they wish to be heard, how we do community engagement better. These are all crucial issues, and they're big research questions as well as big dilemmas for services.
Thank you, Mary. Now, the next question is from Jan van der Scheer, who said, what would help most to build local capability for improvement? Do we need local champions to do healthcare improvement better within their local settings?
Thanks very much. Okay, so several things probably need to happen. One of them is that you do need a local capability for improvement, and the Q community, I think, has been very helpful in beginning to professionalize that and in creating a community of people who know how to do improvement. The second thing is that I think we do need this capability for doing things at scale. So I think it's probably futile in many cases to develop big solutions, things that need to be developed at scale. Leaving that all up to local settings essentially consumes the improvement resource and results in non-standardization and makes people exhausted. And it means you don't necessarily get a good solution because you haven't got the access to the expertise or the resource to do it. So at the same time as you need that local improvement capability, you also need a large scale coordinating mechanism that can help us make that improvement big. I think that would make a huge difference. I think professionalizing some of the aspects of improvement and goes back to Christopher's question from earlier, having specialist teams who can do this and who have networks and are connected in with each other would also make a big difference.
Brilliant. Now I've got a load of questions coming in. I've got 10 minutes. We'll try and get through them all if we can.
I'll be quick.
No, don't worry. Stella O'Brien asked, is there a best way to assess quality and process improvement programs with support for infrastructure to implement them in the NHS? And should it be done locally, nationally, or more centrally?
Thanks very much, Stella. I think you probably need different frameworks for how you plan and assess improvement programs depending on the level at which they're being done. I mentioned during the talk, we are currently working on what good looks like for small-scale local improvement. And the early work we did consulting on that fed back to us. We don't want to know what excellent looks like because that's probably not going to be feasible. What we want to know is what good looks like. What's the kind of minimum viable product we can aim for, and anything over that is a bonus. But what's the kind of, not necessarily the best we can do, but what would good look like? And we've been building that framework, and we hope to publish it next year. Then I think there's another piece on what does good look like for large-scale national programs. And my colleague, James McGowan, has been leading this work, which I mentioned again during the talk, and it's going to appear tomorrow. And that has very successfully built a set of criteria for what good looks like for large-scale programs. And it's used them to assess maternity initiatives. But I think the basic components of the framework that he's been building could be used for most large-scale quality improvement programs. A very important feature of that is, has it involved patients and carers in the design of the program? Another one is, has it got evaluation built in? And another one, going back to Liz's earlier point, is, has it made reducing inequality a priority? So I think there's the beginnings there. And again, I would very much hope that with the right kind of consultation, we can get to a really strong sense of a framework for planning and evaluating local and large scale programs. Thanks again, Stella.
Fingers crossed. Now, I think I know what you're going to say to Hannah's question. Hannah, I think you said it might be tooled or third. I might have got it wrong. If I have, I'm sorry. But you asked, do you think there would be room for clinical improvement as a speciality? Many junior frontline staff on the shop floor have lots of ideas, but aren't given the space to change. And it's hard to get that space unless you're very senior or you haven't had the training.
I think that's a brilliant idea. I would be very keen to see some kind of professionalization of it. I think there's scope for giving particular developing qualifications that people could gain in it, and a career people could have in the same ways. For example, people have very successful careers that are clinical and develop IT. So we've now got roles that we didn't have 10 years ago, clinical information officers. I think we could have clinical improvement officers, same kind of idea. I mean, there are some elements of that beginning to emerge in different places. I think the whole business of early career professionals and their involvement in improvement could be a much better experience for everyone, with this kind of large scale coordinating idea that we're beginning to work up in this institute. So I'm hoping we can share some examples of that this time next year. But I really, really like that idea actually of clinical improvement specialists. Thank you.
It's
Hannah.
Brilliant, isn't it?
Yeah.
So Philip Astor has asked, how best can policymakers be persuaded to invest in improvement approaches? Is it bribery?
I don't think it's bribery, actually, but that's a really important principle here. And I think there has been a period of thinking sort of co-design and evaluation, they're kind of frivolous add-ons or not necessary, nice to have, but not essential. I think we need really compelling examples of how you can get a much better result by doing the co-design. And by doing the evaluation, you're building learning, you're delivering on accountability, you're showing what works. And I think working in that way, so working with the grain, you know, these programs are going to happen anyway. So let's do them really, really well. I feel that that's going to be extremely persuasive. Thank you, Philippa.
The next question is from Nicole Dang, which I think is really topical off the back of the CR UK report yesterday, saying that if we acted now, we could save 20,000 cancer deaths in the next 10 years. How do we shift the debate towards resourcing prevention programs? Because 33,000 cancers are due to deprivation, rather than focusing on treatment and care when the damage has already been done. And as a second question, how do we encourage patients to lead this process?
Yeah, I mean, those findings from Cancer Research UK were very disturbing, and it's clear something needs to be done. So I think there are big societal questions about prevention and how that's well supported, the different levels of prevention. So primary prevention is clearly very important. So we're preventing essentially exposures to carcinogens and supporting people to have the kind of lifestyles that protect them. We can't prevent all cancers through prevention, so there's going to be an ongoing need. Sorry, through primary prevention, there's going to be an ongoing need for improvements at the diagnostic stage, and this is where the NHS sadly is now beginning to lag really quite well behind other high-income countries. So improvements in scanners, improvements in professionals like radiographers, they're going to be key to getting this right, but also improvements in essentially the orientation towards early detection and early intervention, so we don't get people diagnosed very late when it's very difficult to do anything about it. That clearly needs to be invested. And that's actually going to require a lot of process improvement and redesign that has absolutely got to be done with patients themselves. It just seems hopeless to me, and misguided to think you could do this without patients and staff being involved. So absolutely critical. They're there every single step of the way.
And I'm going to go off the wall here and say, maybe we need to get patients, influencers on TikTok and YouTube and Instagram to lead the change and say health prevention is good, and actually think outside the box. But I've got another question. We need to use the patient voice. This is a question from Sarah Kelly, who's asked, is there potential to involve experts in process improvement from other areas, such as industry, rather than healthcare?
That's a very interesting observation, Sarah, and I would say absolutely yes. Now, I think we have in healthcare looked too narrowly at the industries we might learn from. So there was a very long time when people talked about aviation as if that was the answer to everything. There are things to be learned from aviation, but it's quite possibly too simple, if I can say it, too simple a model. I think there's an awful lot to be learned from how they do things in the software industry, for example, where there's an awful lot of rapid cycle testing. I think there's an awful lot to be learned from logistics. And, you know, we've seen in the last 2 decades, logistics companies, which have got their flaws, but they do things extremely efficiently. They get things delivered. They make sure the right thing is in the right place at the right time when people need to use it. Their admin is highly optimized. And I think other industries that we could absolutely learn from include those that are operating in very high risk contexts. I'm thinking of you know, mining and some of these other areas where they have developed safety systems that help them with managing the huge risks that they're exposed to on a daily basis. I think healthcare is different. It's got a relational component, so nobody thinks they have a relationship with that big company that might deliver parcels to people's doors, but you do need to have relationships with professionals. It is an awful lot about relationships, and when we forget it's relationships and we go completely to transactions, that's when I think the problems start to occur. So much as we learn from industry, we also need to learn from the NHS itself and what we know about what good looks like and what caring really means.
Brilliant. I'm going to squeeze in one final question because you've got minutes left. This might be a yes or no. Nia Bromwich has asked, if we link quality improvement with patient safety, do you think it would receive more kudos?
Thank you, Nia. I don't know that I see quality improvement and patient safety as different. I think they're intimately interlinked, and I'd actually like to see the two walk more hand in hand. I think when we have quality improvement operating too locally, then you can get issues in patient safety that arise because, you know, the human factors expertise or whatever it is you need to solve the patient safety problem isn't there. You haven't got the standardization you need to deliver improvements at scale and so on. But I'm not sure I see the two as incompatible. I think the two should enjoy similar status. Brilliant. And should be friends of each other.
Mary, I'm going to have to stop you there, but thank you so much. We've learned so much and you've achieved amazing things here at this institute. I think my takeaway is nothing about the patient without the patient, and it all needs to be evidence-based. So thank you very much, Mary. That was incredible.
Thank you very much. And thanks for all the wonderful questions.